Special Committee on Aging will now come to order. Over the last decade, we have lost hundreds of thousands of Americans' lives to drug overdoses. It's happening in every community, across every state. None of us have been spared from the carnage left by this crisis. And we've all heard the heartbreaking stories of families. Attorneys, generals, law enforcement, advocates, our sheriff departments, police departments. From 2022 to 2023, we saw a drop in overdose deaths from people aged 15 to 54. Now that's good news, but shows we have more work to do. While overdose deaths in the U.S. dropped for people between the ages of 15 and 54, we saw deaths increase from 22 to 23 for Americans who are aged 55 and older, after seeing an increase in the 65 and older age group in 2022. In 2023, more than 29,000 Americans aged 55 and older died from an opioid overdose. That's 80 seniors dying from opioid overdoses every single day. Think about it this way. In the 2 hours we'll spend together in this hearing today, 6 people aged 55 and older will die. Every overdose is preventable. Every single one of those nearly 30,000 lives of older Americans lost could have been saved. While I've all heard the heart-wrenching stories of the children and young people lost to the opioid crisis, the stories that have been largely untold are those about the devastating impact that this crisis is having on American seniors. That includes not only the horrible deaths I just talked about, but also the toll of being a caretaker when parents are impacted by these drugs. I know that we'll hear firsthand today about that from Ms. Mateer. I believe the Aging Committee must take this issue on, and that's why we're having this hearing today. This isn't a partisan issue, it's an American issue, and Congress must act now. Last year, I was proud to have my bipartisan End Fentanyl Act signed into law, which fellow Aging Committee member Senator Mark Kelly co-sponsored. The End Fentanyl Act was a bipartisan success because it exposed just how behind parts of the federal government were when it came to fighting the opioid epidemic and stopping the deadly fentanyl that is killing thousands of fellow Americans. In 2019, a study from the Government Accounting Office found that drug interdiction guidance of the U.S. Customs and Border Patrol Protection had not been updated in 20 years. That's clearly unacceptable. Now that the End Fentanyl Act is law, CBP is required to update its policies at least once every 3 years to ensure operational field manuals, including their drug interdiction guidance, are up to date. These are the kind of common sense policies we need to get done here in Washington. Seeing the End Fentanyl Act become law makes me even more optimistic that we can get things done, and I have more ideas with bipartisan support to combat the opioid crisis. Last week, I reintroduced my Opioid Act with Senator Welch of Vermont. This bipartisan bill is one step we can take to fight this epidemic here and now. It would provide better insight into overdose deaths nationwide. Local law enforcement agencies are on the front lines of this crisis. And this would provide additional grants to support law enforcement in communities with high rates of overdoses. It would make federal agencies collaborate on this problem. And my Opioids Act would stop the bad practice of stealing money from the National Drug Control Strategy and Budget and this would provide additional grants to support law enforcement in communities with high rates of overdoses. It would make federal agencies collaborate on this problem again. I'm also proud to lead a bipartisan awareness resolution each year for the life-saving drug naloxone. As our witnesses know all too well, naloxone literally stops an overdose in its tracks. That is why each June 6th we do a National Naloxone Awareness Day resolution to raise awareness and educate people on the life-saving drug capabilities of something so simple to carry. In addition to those, I also have several other pieces of legislation on this issue, including National Fentanyl Awareness Week resolution, Overdose Radar Act for better health data on overdoses, and Social Media Act to combat illicit online sales of drugs. This is by no means all we can do, but it has to start somewhere. Like I said earlier, I'm optimistic. I know it may seem like there's a clear path forward, but if we keep fighting every single day, I know we can make a change. I look forward to hearing your testimony and working with my colleagues on the next step to fight this issue. I now want to recognize Ranking Member Christine Gillibrand for her opening statement.
Thank you, Chairman Scott, and thank you for calling on today's hearing. There is no community in this country that has escaped the impact of the opioid crisis. Substance use disorders are growing at an alarming rate in the United States. Broadly, 48.5 million people aged 12 or older had a substance use disorder in the past year. While older adults tend to use substances at lower rates than other age groups, 4.6 million people aged 65 or older had a substance use disorder. In the past year, fatal drug overdoses decreased nationally, and while the numbers vary significantly between states, we have the tools to continue reducing overdose deaths to reverse the trend in states where this isn't the case. We know that expanding the availability and affordability of treatments and harm reduction policies like universal access to naloxone are strategies that work. We need to make a multifaceted approach that includes a law enforcement and criminal justice element that places a larger emphasis on public health and social policies. We can't fully address the opioid crisis if we are not also addressing prevention and access to affordable treatment. It's why protecting Medicaid is so critical. Medicaid is the primary payer for substance use disorder treatment. Any cuts to the Medicaid program would devastate our ability to solve this crisis. Another critical piece of the puzzle is the impact of drug use on the whole family. More than 2.5 million children are currently being raised by grandparents or relatives or a close family friend. Over time, more grandparents are forced to become family caregivers because of the opioid crisis. I co-lead the bipartisan Supporting Families Through Addiction Act, which would provide support to the families of people receiving treatment for a substance use disorder. Congress must do a better job of tackling this crisis holistically. I hope to work with my colleagues in the future to develop policies that take every aspect of this crisis into account, from providing necessary public safety tools to making sure those with substance use disorder have access to affordable, evidence-based treatments. I look forward to today's hearing, and I look forward to hearing from our witnesses who can speak to the opioid ecosystem and how we can truly combat the opioid crisis. Thank you, Mr. Chairman.
Thank you, Ranking Member Gillibrand. I'd like to welcome our witnesses here today. Before I introduce our first witness, I'd like to ask each of you to be mindful of our limited time together and keep opening statements to 5 minutes. First, I'd like to welcome Seminole County Sheriff Dennis Lemma. Sheriff Lemma serves as the delegate chair on Florida's statewide council on opioid abatement, created to enhance the development and coordination of state and local efforts to abate the opioid epidemic and to support the victims and families of this crisis. The sheriff has also served as a member of the Victoria's Voice Foundation. Victoria's Voice Foundation does amazing life-saving work to help prevent overdoses by raising awareness of naloxone, a revolutionary drug to stop an opioid overdose in its tracks, as well as educating students, parents, educators, and communities about the dangers of illicit drugs. I've actually worked with Victoria's Foundation now for 2 years to introduce the National Naloxone Awareness Day resolution. I was happy to see it pass to raise awareness of this important opioid tool to combat the epidemic. I've also been honored to work with Victoria's Voice to help get naloxone into more schools and help them partner with school districts so these parents can come in and talk directly to students about the dangers of fentanyl and pain and loss this drug causes. I've also had the pleasure of working with the sheriff for years on these important issues. Thank you for being here, Sheriff Lemma.
Well, good afternoon, Chairman Scott, Ranking Member Gillibrand, and distinguished members of this special committee. Thank you for the opportunity to testify on the devastating crisis of overdoses and fentanyl poisonings in our country. It is an honor to present a proven strategy from the state of Florida, one that can be replicated nationwide. Chairman Scott, your leadership, starting with your time as Florida's governor, when you and Attorney General Bondi took action to shut down pill mills, served as a model for the country. Senator Gillibrand, your efforts through the legislative effort like Fentanyl Act have been crucial in this fight. I also like to recognize Senator Ashley Moody, who, as Florida's Attorney General, provided invaluable leadership in the fight against this epidemic. Her vision and dedication inspired my own focus on this issue, which requires both law enforcement and clinical understanding. I serve as the elected sheriff of Seminole County, Florida, located in the Orlando metropolitan area. Seminole County is the 4th most densely populated county in the state, And despite its affluence, we are not immune to the devastating effects of this crisis. Simply stated, this epidemic does not discriminate. It affects citizens from all backgrounds and demands comprehensive solutions. In my nearly 33 years of law enforcement, I've come to believe that the greatest responsibility of any civilized society is to protect and preserve human life. Overdose death has tragically become a leading cause of death for individuals aged 18 to 45. In 2022, the average life expectancy of a U.S. citizen decreased partially due to the rise in overdose deaths. To effectively combat this crisis, we need a holistic approach that includes prevention, treatment, advocacy for life-saving interventions, and a strong emphasis on law enforcement strategy that aggressively goes after the drug dealers who are dealing deadly doses of narcotics in our communities. Prevention remains a critical tool in the process. Through focused education and awareness, we can equip individuals with the knowledge to avoid addiction before it ever starts. Prevention also requires ensuring the highest level of access to opioid antagonists like Narcan, a life-saving medication that can immediately reverse the effects of an opioid overdose. In Florida, we've made great strides in expanding access to these antagonists, and they have saved countless lives. Treatment is equally important in breaking the cycle of addiction. Medication-assisted therapy combined with cognitive behavioral therapy has proven to be effective in helping individuals recover from substance use disorder in both clinical and correctional settings. Data collection also plays a critical role in combating this epidemic. We need to gather and analyze overdose data at all levels. By understanding overdose trends, we can better allocate resources and target enforcement efforts. However, accountability for drug dealers is absolutely crucial if we're going to put an end to this epidemic. We must ensure that those who distribute fentanyl and other illicit substances, like the emerging trend of street-level xylazine, are held fully responsible for their actions, whether there's an associated death or not. Too often, overdoses are treated as accidents, when in reality, they are crimes. In Florida, we've passed legislation with harsher penalties for those drug dealers whose actions result in fatal overdoses, while at the same time, we've created criminal laws to hold drug dealers accountable for the individual overdoses that we bring people back to life with an antagonist. Drug dealers cannot be let off easily, and the law must hold these individuals accountable to the fullest extent. Additionally, we cannot ignore the illicit drug trade, particularly from cartels like the Sinaloa and Jalisco New Generation, which still pose a threat to our country. Securing the border and preventing fentanyl from entering our country is critical to minimizing its availability and reducing deaths. This crisis must unite us all regardless of partisan lines, because it impacts every community across the country. In conclusion, we must adapt a holistic strategy that includes prevention, treatment, improved data collection, and the strictest accountability for drug dealers. This strategy works, builds safer communities, and ultimately saves lives. Utilizing this strategy in Seminole County, we've achieved a 29% reduction in overdoses and a 42% reduction in fatalities in 2024 alone. While we have seen this reduction, we know that the hard work still lies ahead. Thank you for having me here today, and I look forward to addressing your questions.
Thank you, Sheriff. Now I'd like to recognize Senator Jim Justice to introduce our next witness.
Well, first of all, let me just say this. Greg Duckworth, you know, you're an incredible man, and you've done incredible work. And it's a real honor for me to be able to introduce you. But I've got to just say just this. I said this earlier today, but can you just imagine West Virginia, how hard West Virginia was hit? It was unbelievable, unimaginable in every way. We had to have people that really stepped up, people that were superstars. This man's a superstar. He's 27 years, I think, a veteran of the state police and absolutely a superstar in every way. With all that being said, let me just tell you this story very quickly. You know, Baby Dog and I go through a lot of drive-through windows, and maybe we shouldn't go through that many. But just the other day, we're going through the drive-through window at Arby's, And I looked up, and the car right in front of me had amber and had a cross, and had 1993, 2023. Well, we made it to the window to pay for our food, and the car had left, and they paid for our food. Now, we tried to run them down. We finally, through a lot of different ways, through the state police, found them. Amber had played basketball for me as a coach. So many situations to where all of a sudden a drug takes a life. It's happening all over the place. Greg, I mean this with all in me. It's an honor to introduce you. You've done great work with our foundation in West Virginia. You have absolutely been just what I've just said. You've been a superstar because you care, and I am really proud to introduce you. Thank you so much, Mr. Chairman.
Thank you very much. Chairman Scott, Ranking Member Gillibrand, and my fellow West Virginian Senator Justice, and other members of the committee. Thanks so much for having me here today. It's truly an honor. I spent my law enforcement career in the heart of the opioid epidemic in an area once known as the coal fields. Today, I want to share some firsthand experiences on how this crisis has devastated families, affected our aging population, and where we must focus our efforts moving forward. In 2012, 17-year-old Cheyenne Martin reported to the police that her father and two younger siblings were missing. She had already lost her mother, Carrie Hendricks, who, under the influence of OxyContin, had wandered into the highway and was fatally struck by a truck. During the missing person investigation, police found that her father, Hendricks, was lured into a trap by an OxyContin dealer named Belknap, who owed him money. Hendricks, his girlfriend, and the two youngest children, ages 6 and 4, were ambushed and murdered, and their bodies were discarded as if they were worthless. A decade later, Cheyenne herself died of an opioid overdose, leaving behind 3 small children. Entire families are being erased by addiction. This is not just a crisis of individuals, it's a crisis of generations. Children lose parents, and grandparents are forced back into parenting, and communities crumble. The second story involves a single mother in her early 30s with 4 children, a 9-year-old, a 7-year-old, and 3-year-old twins. For years, she lived with her mother, who helped care for the children. Recently, she had moved into her own place, a single-wide trailer within walking distance of her mother's home. At night, after dinner, she would take the 3-year-old twins home while leaving the older children with their grandmother, who would ensure that they got to school the next morning. The twins were described as full of life, radiating joy as most 3-year-olds do. One night, the mother put the twins to bed, and by the time she checked back on them again, they were deceased. Autopsies revealed multiple drugs in their systems, including lethal amounts of fentanyl. The neglect was so severe that rigor mortis had already set in before she even realized what had happened. The children's grandmother had already lost her husband to cancer, and she is fighting for custody of the remaining children, but has been unsuccessful. She is, however, allowed to see them with the help of the Child Protective Services. The mother is currently in jail, awaiting trial on 2 counts of child neglect resulting in death. The burden on our seniors in West Virginia, 1 in 7 children lose their parents to overdose or incarceration by the age of 18. With the highest rate of neonatal absence and syndrome, many of these children have medical and developmental challenges. Grandparents who thought they were retiring are now primary caregivers. They face physical strain, raising young children at advanced age, financial hardship. Many live on fixed incomes and struggle to meet basic needs. Emotional toll, raising children while still grieving the loss of their own. And many of this is off the record to avoid the foster care system. So they don't receive financial or legal support either. The West Virginia First Foundation is supporting grand families and the aging population. And I'm proud to serve on a board of the West Virginia First Foundation and to be part of this organization that is making a real difference in our communities. The foundation is committed to addressing the full impact of the opioid epidemic, including the burdens placed on West Virginia's aging population, recognizing that addiction does not just affect the individual, but entire families. The foundation is dedicated to supporting grandfamilies, the grandparents raising grandchildren, by providing resources and assistance to child advocacy and youth prevention programs. We recognize that the crisis did not end with one generation. It continues to ripple outwards. And by investing in solutions that support full family systems, the foundation is helping to break the cycle of addiction and ensuring that grandparents raising grandchildren are not left to struggle alone. Where we must focus, having served on the front lines of the epidemic, I believe that our response must be comprehensive. Treatment access, prevention and education, recovery support, grandfamilies and child advocacy, and of course, economic recovery. We also must fix some of the systemic failures as well, the underreported overdose deaths, the inconsistent Narcan use documentation, and recovery homes misclassifying overdoses. In closing, I believe we have to restore hope, and substance use disorder is our enemy. It's destroying the very core of the American way, God, family, and self. To win the war, we must ensure the love of the church, reunite families, and emphasize the importance of family values, and bring back support systems that give people a sense of self-worth. The crisis is more than just statistics. These are real people with names, faces, and stories. If there's one thing I want you to take away from today, is that behind every number, there's a human being. Thank you.
Thank you, Commissioner. Thank you, Senator Justice. Next, I'd like to recognize Ranking Member Gillibrand to introduce the next witness.
Thank you, Chairman Scott. I want to introduce our next witness, Ms. Elizabeth Matier. Ms. Matier is a grandparent who has been raising her grandson for more than a decade due to his parents' opioid use disorder. Ms. Matier, thank you so much for sharing your story with us here today. You may begin.
Chairman Scott, Ranking Member Gillibrand, and members of the Senate Aging Committee, thank you for holding this important hearing and for inviting me to share my perspective. My name is Elizabeth Matier. I am a grandmother raising my grandson due to the impact of opioids. I also volunteer as a Generations United Grand Voice caregiver advocate. When my grandson was born, I had no idea that my life would change forever. I did not know the baby was suffering with neonatal abstinence syndrome. I also had no knowledge about opioid use disorder, so at first I did not identify and understand the harsh reality that both parents were addicted to painkillers. When we learned of the mom's opioid use, my husband and I intervened and arranged for her to be admitted to a treatment facility. Suddenly, we had a baby. Although we were very relieved and hopeful for the future, we had no crib, no diapers, no baby clothing, no formula, and no idea where to start. 10 days later, I would receive a phone call that Mom was leaving treatment. We would not hand our infant grandson back to parents who were using. Fear drove us to find an attorney who obtained emergency custody, but a few weeks later, the parents cheated a drug test, and we were ordered to return the baby. Why do judges misunderstand opioid addiction and the risk in placing children with parents who are in active addiction? The cycle of staging interventions and arranging for admissions to treatment continued. Early on, one interventionist told me to be prepared to keep my grandson long-term because this would go on for a long time. Each relapse was a crushing blow, and each time the recommended length of inpatient treatment increased. The staggering cost for some treatment facilities included $30,000 deposits for admission and $10,000 a month. I constantly battled with the insurance company. Opioid addiction is like none other. It takes a person's soul and turns them into someone you don't even recognize. We were desperate to save both mom and baby. The stress of living in this opioid-created crisis landed me in the hospital with pneumonia in both lungs. While we were trying to help our grandson's mom get treatment, we were fighting a custody battle with the father, who was still in the throes of opioid addiction. Our legal fees exceeded $85,000. The court was permitting supervised visits that were actually not being supervised. We worried every time we went to court. The court halted visitation privileges when we learned that the father had been charged with child endangerment of another child under his supervision. 6 months later, he died of a heroin overdose. When I told my then 4.5-year-old grandson that his father died, the first question he asked was, "Will I still be able to live with you?" I found that working and caring for a child was harder than when I raised my own children. I had to leave my job. My relationship slowly disappeared. Friends stopped inviting me to social events since I didn't have childcare. I felt isolated as my husband traveled for work. The stigma of addiction that the child I raised could not raise their child made me feel ashamed. No one knocks on your door with a lasagna in hand to comfort a family in this kind of a crisis. My clergy never called. Depression set in, and I wondered, how would I go on? By the grace of God, our grandson's mother has been clean for a long time. Our relationship is challenging because her son, now 13, wishes to remain in our home. During the years of battling her addiction, he just grew up. This is his community, his home where his pets live, where his school is, where his friends are. My husband delayed retirement so we could provide for our grandson, and it is nothing like we envisioned driving the middle school carpool and hosting the baseball team picnic. We hope to stay healthy so we can be there for our grandson. The staggering number of grandparents who care for their grandchildren, often without any support, is one of the least recognized populations impacted in the opioid crisis. Grandparents and other relatives who step forward to keep children out of foster care and safely with family save taxpayers more than $4 billion a year. The child welfare system would collapse if grandparents did not take in these children. Any grandparent raising a grandchild could use financial help. I urge you to consider these recommendations. Encourage states to distribute opioid settlement money to help children and caregivers. Promote peer support. Being part of Generation United's Grand Voices Network has been a godsend to me. I was once told that opioid addiction in a family is like pouring acid on it. Expand the number of mental health providers with expertise in grandfamilies. When we enrolled in Medicare, our grandson lost his health insurance. Expand health care coverage options so grandparent caregivers on Medicare have coverage for the children they are raising. Allow grandchildren who are in the legal guardianship of their grandparent to qualify for Social Security survivor benefits if the grandparent dies. SNAP can be a lifesaver. I urge you to protect this program. Continue support for Kinship Navigator programs that provide information about community-based services. I cannot imagine what my grandson's life would have been in foster care with strangers. Grandparents are committed to protecting the children in their care, but we need help. Thank you.
Thank you. Go ahead.
Do I do the next one? Oh, yes. No. Thank you, Ms. Mateer. Our next witness is Dr. Malik Burnett. Dr. Burnett is an addiction medicine provider and the medical director of several community opioid treatment programs in Baltimore, Maryland. Dr. Burnett also serves as the vice chair of the Public Policy Committee for the American Society of Addiction Medicine and oversaw naloxone distribution for the state of Maryland. Thank you for being here, Dr. Burnett. You may begin your testimony.
Chairman Scott, Ranking Member Gillibrand, esteemed members of the Senate Committee on Aging, I thank you for inviting me to participate in this critically important hearing. My name is Dr. Malik Burnett. I'm a board-certified addiction specialist physician who takes care of patients with addiction and co-occurring conditions in Baltimore, Maryland. Today I'm testifying in my capacity as Vice Chair of the Public Policy Committee for the American Society of Addiction Medicine, known as ASAM. ASAM is a national society representing over 8,000 physicians and other clinicians who specialize in the treatment and prevention of addiction. I want to begin today by talking about Baltimore and its forgotten generation. Older adults born between 1951 and 1970, particularly older Black men. In my city, one in 3 drug overdose deaths come from this demographic. Illicitly manufactured synthetic opioids are among the deadliest health threats that they face. Many of these men have struggled with addiction for years, but today there's no margin for error. A single relapse can leave them at the mercy of a lethal dose of fentanyl or other synthetic drugs. While addiction is a treatable chronic medical disease, it is also one of the most complex in medicine. It involves interactions among brain circuits, genetics, the environment, and an individual's life experiences. As a result, solutions to our nation's addiction and overdose crisis can be equally complex and interconnected. Supply-side approaches are important to public safety, but yield little net benefit if demand-side interventions remain inaccessible, underfunded, and undermined. Drug cartels can quickly replace confiscated synthetic drugs with little effort and overhead, ensuring unbroken access to dangerous drugs, fueling this overdose crisis. The good news, evidence-based addiction treatment works and reduces the risk of overdose death by 80%. As a physician, I've personally witnessed hundreds of patients' lives transformed by addiction treatment. People in treatment restore their marriages, rejoin the workforce, leave criminal activity, improve their mental and physical well-being, reunite with their children, and yes, escape the grasp of drug cartels. We are fortunate to live during a time when effective evidence-based treatment exists for opiate use disorder, yet tens of thousands of people in the U.S. continue to die from illicit opioids annually. How is this possible? Unfortunately, the people who need these treatments the most are not getting the life-saving care that they need when they need it. In fact, it's this treatment gap that's barely budged for the last decade. We will not end the opioid epidemic until evidence-based addiction treatment is easier to get than illicit opioids. For many Americans, especially in rural areas, evidence-based addiction treatment is impossible to find. Ease of treatment access is critically important because people with addiction often experience a brief window of time between desiring treatment and experiencing painful withdrawal symptoms, symptoms that cheap fentanyl, which is easier to get than addiction medications, can temporarily stop in an instant. But easier access to addiction treatment cannot happen without a substantially larger addiction treatment workforce, including more addiction specialist physicians, increasing federal funding for addiction medicine and addiction psychiatry fellowships, and financial incentives to encourage more physicians to enter these training programs are sorely needed to ensure every community has high-quality addiction treatment. In addition, federal law must be amended to allow these addiction specialists to prescribe methadone for opioid use disorder that can be dispensed from community pharmacies. Today, only about 2,000 opioid treatment programs dispense methadone for opioid use disorder. They are lacking in about 80% of U.S. counties. Methadone for opioid use disorder has been caught in bureaucratic red tape for nearly 50 years. Allowing states to regulate their methadone treatment without undue federal restriction could lead to the type of innovation needed in opioid treatment in America. Yet connecting individuals to treatment is not enough. They must also be able to afford their care. Medicaid and Medicare are major insurers for people with opioid addiction, making it essential that these fiscal mechanisms facilitate rather than hinder access. Many clinicians in opioid treatment programs do not accept Medicaid, largely reflecting the program's administrative burdens and low reimbursement rates. Congress should remove these burdens and increase Medicaid rates to change this equation. Medicare and Medicaid must also cover the full continuum of addiction care. Surprisingly, Medicare does not cover non-hospital-based residential addiction treatment. This must change. Furthermore, assurance of equal reimbursement for mental health and addiction care must be strengthened by levying civil penalties for parity violations and incentivizing state regulators to be more robust in their enforcement. Stigma towards addiction is arguably the most difficult barrier to address, as it's so entrenched in society. Even when people recognize that they have a problem with drugs or alcohol, they're often too embarrassed or too scared to talk to their physician about it. The federal government should stop wasting money on incarcerating people for nonviolent drug offenses and must continue to emphasize that addiction is not a disease, but addiction is a disease and not a moral failing. People already in the criminal legal system also need better access to addiction treatment. Congress should eliminate Medicaid's inmate exclusion requirements, and federal funding for prisons and jails should be contingent upon providing evidence-based addiction treatment to ensure that taxpayer money is not wasted on a revolving door of incarceration. In closing, thank you for the opportunity to share my perspective and expertise today. One thing is clear about America's opioid ecosystem, whether it's funding and training more addiction specialists, ensuring access to prescription methadone, closing Medicare coverage gaps, avoiding harmful cuts to Medicaid, or enforcing equal access to addiction treatment in all healthcare settings. Congress owns this. Let's work together to save lives. Thank you, and I look forward to answering your questions.
Thank you, Dr. Burnett. Mr. Chair, I've got a 13-year-old grandson. I can't imagine trying to stay up with him as a parent, as my daughter and my son-in-law have to do. So, but thank God he's got you in his life. I'd like to introduce Dr. Bradley Stein. Dr. Stein is the director of the RAND USC Schaefer Opioid Policy Center and a senior physician policy researcher at the RAND Corporation. Dr. Stein has worked extensively examining the effect of state policies and community outcomes related to the opioid crisis. Thank you for being here.
Thank you. Good afternoon, Chairman Scott, Ranking Member Gillibrand, and distinguished members of the committee. Thank you for inviting me to share insights on combating the opioid crisis, which is increasingly impacting older Americans. As the chairman said, I am a senior physician policy researcher at RAND and direct an NIH-funded research center devoted to better understanding the effectiveness of opioid-related policies. I'm also a practicing child psychiatrist in Western Pennsylvania, where I see firsthand how opioid addiction devastates families across generations. The toll of the crisis extends far beyond fatal overdoses. It affects millions of Americans, not just older adults fighting to maintain their own recovery, but also those spending their life savings to pay for adult children's addiction treatment or raising their children's children. Today, I will focus on 3 topics particularly relevant to this committee: what escalating rates of opioid use disorder among older adults imply for healthcare, how upstream strategies of better chronic pain management can help prevent opioid misuse, and the social toll of grandparents raising grandchildren due to parental addiction. Opioid use disorder rates have tripled among Medicare beneficiaries over the last decade. The rapid increase poses significant challenges to our healthcare system, which is not adequately prepared to address the unique needs of this population, who often have conditions that can complicate diagnosing and treating opioid use disorder, like dementia or chronic pain. Primary care providers, the clinicians at the heart of treating our older adults, often lack training or confidence in managing opioid use disorder. Meanwhile, few addiction specialists are equipped to handle the complex medical needs of older patients with conditions like dementia. This mismatch leaves many older adults with opioid disorder without adequate care, especially in rural areas experiencing acute clinician shortages. The American population is aging, but currently most clinicians treating chronic disorders in older adults don't have expertise in substance use disorders. And substance abuse experts treating older adults who have addiction usually have little experience in treating chronic disorders in the elderly. Only with concentrated efforts and federal investments will the clinical workforce caring for the elderly be prepared to efficiently and effectively treat individuals with opioid use disorder and disorders like dementia. And chronic pain is even more common than dementia, affecting 36% of those over age 65. Efforts to reduce opioid prescribing have curbed misuse. But many individuals with chronic pain don't receive non-opioid treatments, leaving many without adequate pain management options. Some clinicians now avoid prescribing opioids altogether, even when they're clinically appropriate, leaving patients to suffer or turn to illicit opioids for relief in some situations. Expanding access to non-opioid pain management is essential to address this gap and can help prevent new opioid use disorder cases. Acupuncture, rehabilitative exercise, therapeutic massage can all reduce reliance on opioids and improve quality of life for individuals with chronic pain. However, insurance coverage is often inconsistent or limited in scope, and high out-of-pocket costs often make these non-medication therapies less affordable than opioids, and provider shortages can make this care very hard to find. Congress can help by considering incorporating non-opioid therapies for chronic pain in value-based insurance designs to enhance affordability and ensure that these services are fully covered by Medicare. It can also possibly consider expanding existing loan forgiveness programs, such as rural health grants or the National Health Services Corps, to include providers trained in these non-medication therapies to ensure we have an adequate workforce in the future. Finally, as we've heard, the opioid crisis has far-reaching social consequences for older Americans beyond their own health needs. An estimated 2.6 million grandparents are raising grandchildren, often becoming informal caregivers when parents struggle with addiction or succumb to overdose. Doing so often entails significant emotional and financial burdens as grandparents working to keep their family together, delay retirement, or take on new expenses like housing or childcare. These older adults deserve better support systems, expanded access to respite care and kinship navigator programs, and information to help them raise children affected by parental substance use and trauma. Yet informal caregivers, commonly outside the child welfare system, often don't receive such supports, despite the vital role these individuals play in providing stability for so many children. Congress can help support these families by expanding access to respite care and affordable child care through programs like Head Start or alongside the Child Abuse Prevention and Treatment Act, CAPTA reauthorization. It can seek to ensure grandparent caregivers have access to benefits such as health insurance for the children and kinship navigator programs, whether they participate in the formal child welfare system or not. and it's important that we support the development of educational resources tailored specifically for grandparents, stepping up to raise children affected by parental substance use disorders. Supporting grandparent caregivers not only strengthens families, but also reduces long-term social costs associated with parental addiction. There's no single solution to the opioid crisis, but healthcare reforms, improving non-opioid chronic pain management, and better supporting families affected by addiction, like so many of the patients I treat, will help keep families together and ensure that our healthcare system is better prepared to meet the diverse needs of older Americans. Thank you again for this opportunity, and I look forward to your questions.
Thank you, Dr. Stein. Thanks all of you for being here. Now we'll start going to some questions. First, we'll start with Senator Tuberville.
Thank you, Mr. Chairman. Dr. Stein, I spent 40 years coaching, and all those 40 years, I saw the correlation between family and some kind of addiction. There's a direct correlation, and if we don't figure out something to do with family in this country and get back to mom and dad and discipline and responsibility, we're going to have a tough time and continue to have a tough time. Also, I saw over the years, I'd bring young men into my football teams, and of course, with their mom and dad, you know, for 4 years, and we'd bring doctors in, and for first part of my career, you know, we had a few that was on insulin for sugar diabetes or something. But my last 10 years, there was very few that was not on Adderall or Ritalin for attention deficit. Kids are over-prescribed by doctors for some reason. Do you see a direct correlation between over-the-counter drugs or prescription drugs that lead to addiction?
Thank you for that question, Senator. You know, this is a question that scientists have been looking at. And so far, the data really suggests that there isn't a direct relationship between children receiving some of these medications and later addiction. But I also think it's important to recognize that we also do recognize that there is a relationship between mental health disorders in children generally, or in adults, and substance use disorders. And so I think it's important that recognizing that there is this relationship and individuals may have both mental health disorders and substance use disorders. I do think it's very important to make sure that not only while we're here focused on opioid use disorders and substance use disorders, to try to address the opioid crisis or substance use disorder crisis more generally, without recognizing how many of those individuals also suffer from mental health problems, really makes us suggest we're trying to fight that battle with one hand tied behind our back.
Do you think we need to roll back the prescription of childhood drugs of what I was just talking about a few minutes earlier?
Sir,
Are we overdrugged is what I'm asking at a young age?
So that's well beyond sort of the research that I'm currently involved in. As a clinician, I can say it's important that we need to make sure that we're using medications and other therapies appropriately. And that means making sure that individuals who are not being treated and may benefit from medications do receive them, and also making sure that we're not providing medications to children or adults who may not benefit from them.
Thank you. Mr. Duckworth, how have states like West Virginia used opioid settlement funds to fight back against epidemics?
That's a great question. The West Virginia First Foundation is brand new. It's in its infancy. So May of 24 was one.
How is it funded, by the way?
It's the opioid settlement money. So the executive director actually wasn't hired until May of 24. So between May and September, it took a lot getting the homework done, the policies, procedures, the staff hired. So we put an initial opportunity grant together that went out for application, receiving applications in September. So by the end of December, we've committed over $20 million. And most of it at this point has went to youth prevention and child advocacy. And I think we'd all agree that the hidden epidemic of our seniors isn't really so hidden anymore. So I can anticipate in the future having a lot more funding going towards the grandparents raising grandkids, the seniors. That's the direction we want to go in West Virginia. To answer your question on the short term, child advocacy and prevention education, things like that is where it went recently.
Yeah, do you think there's anything that you use that we could do on a federal level to help more from this program?
I think Senator Scott's on the data sharing, education, the data sharing, the support for law enforcement. I think it's so important, and I love the mission that you're on there, and hope we can see that come together.
Thank you. Sheriff, we've heard a lot about how children are now able to purchase drugs, which are often laced with fentanyl. And there's this god-awful stuff that you can go into one of these convenience stores and buy that all of it's made in China that's for some reason we're allowed to be sold here in this country. What can we do here in Washington to curb practices and raise awareness to parents about the things that the kids are able to buy?
Well, thank you for the question, Senator, and you're spot on. I mean, Chinese really created this epidemic, illicit substances, and now we've seen the most recent numbers, actually 50% of the pills that are made in clandestine labs or somebody's dirty bathroom in many cases contain a lethal dose of fentanyl. And that's down from a 70%. 7 out of 10 people that were taking it for the first time were likely to die with a pill that was manufactured in an illicit environment. But we see these things, these trends. It was just yesterday when we were talking about methamphetamine, MDMA, flunitrazepam, rohypnol, where roofies were available. And then things got confusing for Americans with designer drugs, where they would walk in and illicit chemists would stay one step ahead of what the DEA would approve as illegal, and we would clean the shelves off. I think we have that under control now. There's no longer a problem in this country of overprescribing. Clearly, you have to have your head in the sand to not realize that we have a problem that's down at our southern border with Mexican chemists now picking up precursor chemicals from China and learning how to process this. But education is so incredibly important. That's why when we talk about greater access to opioid antagonists, the most significant thing that we can do to prevent people from having a drug overdose is never starting. But many of us remember Nancy Reagan saying, just say no. Well, just say no works incredibly well if you've never started. So when people have started on a regimen, we have to give them access to science-based, medical-based treatment therapy combined with cognitive therapy, and not just do that for the person on the journey. Make sure that the family members and the loved ones and partnership with businesses and corporations and the private companies have a big role to play in that, because many people who are on this journey are actually going to an environment, whether they're going to a public school system or that type of environment, or they're going to work. Somebody is formally supervising them, and when they first see the first signs of it, it's important to not only say something, but know what resources are available and stay current with the current trends. Lastly, we all remember the program DARE, which was an incredibly successful program across the country. But DARE had nothing to do with what the challenges are of our kids today. Sexting, texting, cyberbullying, vaping, all of these other things have to be incorporated in educational curriculums K through 12.
Thank you.
Thanks, Senator Tuberville. Senator Gillibrand.
Senator Kim, would you like to take the time?
Sure.
Go ahead.
Thank you. I appreciate it, Ranking Member. Ms. Matera, I wanted to just start by just saying how grateful I am that you took the time to come up here and share your personal story. It's so important that we talk human about the difficulties that are faced. And I'll be honest with you, I've heard a lot of stories about the opioid crisis, but I haven't heard as much about the challenges that it puts upon grandparents. And I thought that was very powerful. I wanted to ask you, I don't know if you have this offhand, but you were talking about numbers and figures in terms of how much, in some ways, is being saved by grandparents stepping up. But is there an actual figure in terms of the estimated number of grandparents who are in this situation right now, like you?
Thank you for the question. And to my knowledge, according to what Generations United has at their fingertips, the grandparents taking care of their grandchildren save $4 billion a year. That's the number I know.
But do we have a sense of how many grandparents are in this situation?
Yes, we do. There are Probably, I know there are around 2.6 million children in our country being raised by caregivers other than their parent. And of those, the majority of them are being raised by grandparents. There is a website that has statistics for every state, and I think it's grandfamilies.org. And if you look at that, where I'm from in Pennsylvania, I know there are over 250,000 grandparents or children in Pennsylvania being raised by other caregivers. Okay. And it does show you the grandparent statistics. But the problem is a lot of these situations stay under the radar because they're unreported and they're not part of the system. So there are probably many more than we know about.
Yeah, and I think that stands to be something that this committee can try to look into, because kind of as Dr. Stein was saying, like, we want to make sure that support is available to all that are struggling. We don't want to have bureaucracy getting in the way, or regulations in that specific way getting in the way of getting support out to those that need it. So thank you for illuminating me on this. And I certainly promise to continue to follow up with you and others to figure out how we can move this needle forward, both in terms of the caregivers, but Dr. Burnett, what I've come to understand is just not just the challenges it is to the caregivers, but that we as a nation right now are not resourced in terms of the workforce needed to be able to address it, both from a practitioner standpoint and more broadly against other types of addiction-related specialists. So I guess I wanted to ask you, what can we do at the federal level to try to increase that sense of workforce to make sure we can rise up to the magnitude of this challenge that we face?
Sure. Thanks for the question. One thing I would say that we can do is reauthorize a couple of different programs. One called the Substance Use Disorder Treatment and Recovery Act Loan Repayment Program, which is the STAR LRP program, is a great program that provides loan reimbursement for providers and clinicians up to $250,000 to work in mental health professional shortage areas or in places where the overdose rate is greater than 3 times the national average. Also, there's another HRSA program that currently exists that could be reauthorized that provides fellowship support for addiction medicine and addiction psychiatric fellowship programs to be able to increase the number of these types of providers, because currently we're about at half the capacity that is estimated to be needed to be able to address and treat the current substance use disorder need for the country.
And one thing you raised as well was, just the challenge sometimes of getting providers to be able to engage with Medicaid, for instance, and you were actually suggesting maybe increasing the rates to be able to try to get more providers on board. But I guess I just want to end here. We're having a debate here in Congress, in the Senate, about Medicaid right now. And I just want to hear from you, just what you think would happen if we saw cuts to Medicaid. What would happen to our ability as a nation to respond to the opioid crisis?
Sure. I think Medicaid is vital to the ability for us to be able to take care of our patients with substance use disorder. I'd say about 80% of the patients in my clinic utilize Medicaid as the financing mechanism for their care. If we were to cut Medicaid funding, it would significantly reduce our capacity to be able to fight the addiction crisis fundamentally.
Thank you. And with that, I yield back.
Senator Justice.
Thank you so much, Mr. Chairman. I'm going to be very official. I'm going to call Greg Mr. Duckworth. But I have 2 questions. I really do. The first question is about our aging, but of course, you've seen the crisis on both sides. You've seen it from the law enforcement side, and you've seen it from the community advocacy side. What does this particularly affect the aging how does this particularly affect the aging population in West Virginia?
Thank you for that, Senator. It starts with a grandparents raising their grandchildren. So if a grandparent is raising a grandchild, we've lost a generation out of their family tree. So the senior is mourning the loss of their child and raising their grandchildren. But it's not just grandparents, it's great-grandparents, and there's great aunts and great uncles that are also raising children. So it's like the floods and fires. Everything that it touches, it destroys. And it starts with the babies being born with addicted to the opioids, or in West Virginia, we have a large amount of babies being born addicted to Suboxone. So we're dealing with the neonatal absence issues and the seniors who are mourning the loss and raising their grandkids. It's a huge impact. 40 to 50% of West Virginia grandparents are raising their grandchildren.
I hope everyone heard that, the magnitude of the percentage in West Virginia of grandparents that are raising the grandbabies. It's terrible. That's all there is to it.
Sir.
And I've said this over and over and over, but I said this when I was governor. I said, if we don't really get a handle on this, it will cannibalize all of us. And we better absolutely get a handle on. There's so much more we can do. I've got one more question, and it's just this, I'd like you to talk about the ways we can see hope restored. When it really boils down to this level of crisis, what really keeps our West Virginia families even going? Greg, we started with Jim's dream, and then we went to Jobs and Hope, and we made a dent. But there's got to be a lot more dents. That's just all there is to it. I've said so many times in life that you'll never get out of the hole till you know really where you are in the hole. And the hole in this situation is bad. That's all there is to it. So I just think that we have got to give people all across this land, if not all across the globe, hope. I mean, optimism, a chance to be better. Absolutely, this situation has got to have every single one of us, arm in arm, pulling the rope together. We can do it, but that's exactly what we've got to do. So tell me your thoughts real quickly on how do we address this terrible crisis and give hope to our West Virginia families?
Yeah, thank you for that. In my mind, the treatment centers and the detox centers, the doctors, they do a fine job for that 30 days. And then our addict gets released from either jail or a recovery home, and there's nowhere to go except back where they came from. So there's a piece of this in the economic development part of creating jobs so that when these folks get detoxed or they get out, they have hope for a job, something they can support their family in. And that's where we lack sometimes, is a place for them to go either when they get out of jail. The overdose rates are highest when someone first gets out of jail or out of a treatment program and they don't have a place to go to, a recovery center or somewhere different than where they came from. And they just go back to the community they were in to start with.
Isn't that exactly what we tried to do with Jobs and Hope? And I would tell everyone just this. We have to have treatment. We know we have to have treatment. And we know we have to have sympathy to bring people back. But these people got to have a job. They have to have training. They can't be trained on a pickup truck how to drive a dump truck. Absolutely, they got to have real life training. And we got to spend dollars to be able to do that. But I thank y'all all so much for being here. Thank you, Greg.
Thank you.
Thank you, Senator Alsobrooks.
Thank you so much, Mr. Chair, for hosting this important hearing today. Thank you so much as well to each of our witnesses. Baltimoreans are dying from overdose at a rate never seen before in a major American city, with the number of deaths quadrupling over the last 10 years. The frequency of overdose deaths in senior homes has likewise increased. More than 340 people have died in Baltimore senior housing complexes in recent years. Black men aged 55 to 74 lead drug fatalities over all other demographic groups in the city, a death rate that is 20 times that of the rest of the country. Yet this administration is working to slash funding for research, treatment, and our public health workforce. Nearly 1 in 10 employees at the Substance Abuse and Mental Health Services Administration, known as SAMHSA, were just recently summarily fired by this administration as a part of DOJ's government-wide cuts. Cuts at SAMHSA threaten continued access to essential mental health and substance use services, including crisis support and suicide prevention, And as you know, SAMHSA is yet another federal agency that is based in Maryland. So I'd like to start with Dr. Burnett. First of all, to thank you so much for the work that you have done every day on the front lines of the opioid crisis in Baltimore. And just want to ask you, how will public health efforts be impacted by this administration's slashing of the federal workforce at SAMHSA? And will leaving SAMHSA with a skeleton staff worsen the situation on the ground in Baltimore?
Thank you, Senator. Also, Brooks, I can answer definitively and talk about a little bit about my experience working for the Maryland Department of Health and how SAMHSA funding was integral to not only ensuring that prevention and public health efforts around opioid overdose were implemented. The SAMHSA funding supported a large percentage of our efforts towards naloxone distribution statewide. And so any cuts to SAMHSA funding would significantly curtail our ability to be able to provide naloxone across the state of Maryland. And I'm sure that that's true for many other states here. And it's particularly true in states that have not expanded Medicaid. SAMHSA funding provides integral not only prevention support, but treatment support in places where patients don't have access to Medicaid. You can provide the funding from SAMHSA to be able to get into community health programs so that people can get access to medications for opiate use disorder. So it's very, very critical funding.
Thank you. You know, also, it's really shocking, but the New York Times recently reported that dealers are targeting senior apartments in Baltimore. Yet health officials have done little targeted outreach to older people. We're seeing that this is an epidemic that is affecting them. So what more can be done on the ground to help address the pattern of deaths among low-income seniors and to stop vulnerable communities from being preyed upon?
I see that every day in Baltimore where I work. We have a senior living facility just down the street from our opioid treatment program, and we've taken steps towards partnering with the senior community to be able to talk about treatment and recovery. You know, the population of seniors experienced opioid treatment in the years before major reforms to opioid treatment took place. And so they have a very negative perception of opioid treatment, very strong stigma towards medications for opioid use disorder. And so there's got to be a significant amount of education to be able to bring those individuals back into treatment. And so it requires partnerships and peer recovery support services going into these senior homes to be able to talk about what recovery looks like and being able to access medications and really reducing the stigma associated with opiate use disorder because it's very pervasive within the community.
No, I think there was a question that addressed at least a part of this, but also, would you speak to the importance of supports for seniors who are caring for children impacted by the opioid crisis, and how does keeping families together reduce the trauma experienced by these children?
Just to clarify, was that question for me?
And that's for anyone who might want it, who can answer.
I'm happy to take the question. In my clinic, one of the things that we really look for in terms of people's capacity to recover is their connection to community and having family support. Sometimes people come into treatment and they are by themselves. They don't have any social support systems. And so it's critical towards your recovery process if you actually have people that can help you through the process. It's a long one. It's much more than the 30-day time frame that most treatment access provides. And so it's really critical that you have family members, especially if you're in an older generation and you're caring for younger individuals, that support and that community-based experience is critical to being able to help people get into recovery, because a large percentage of people who suffer from opiate use disorder are wholly disconnected, right? They're suffering from trauma. They don't have any resources or any places to turn to, and so they use drugs to cope with their isolation. So being able to bring them back into the community, whether through faith-based organizations, community partnerships and relationships, nonprofit organizations, all of that is critical to their recovery.
Thank you. Thank you.
Thank you, sir. Senator McCormick.
Mr. Chairman, thanks for hosting this important meeting on such an important topic. Good to see some fellow Pennsylvanians on the panel, so thank you for being here today to talk about such an important issue for the Commonwealth of Pennsylvania and the country. 4,000 Pennsylvanians died last year from fentanyl, about 100,000 nationally. This is a crisis of sort of historic proportion. I see it all the time in Pennsylvania. I was in Cambria County a couple years ago, and I talked to a woman, and she was describing a family member who died of fentanyl poisoning and the devastating effect on her family. So I started to make these campaign visits. I'd ask people, who among you has been affected by fentanyl? Almost half the people in the audience would put their hands up, either their immediate family or their friend group affected by fentanyl. So we've got to get our hands around this. And of course, it's a problem that begins at the southern border primarily with prefactors from China, comes across our border, and then goes out into a network of drug dealers and cartels in the United States. So my first question is for you, Sheriff Lemma, about the coordination among law enforcement. And is there any gaps you see in the way the federal, state, various law enforcement bodies coordinate, and any insights you can give us on what we might do better?
Yes, thank you for the question, Senator. And I think that first, there were gaps. I think that we're reining those gaps in right now. I think that there is potentially some confusion and need for deconfliction in the past between the law enforcement agencies that worked under the Department of Homeland Security Secretary and those that worked for Maine Justice. I suspect now those problems are going to be cleaned up pretty quickly. I do think deconfliction is incredibly important, not only between federal agencies, but local, state, and there's platforms and relationships and task forces that are a huge benefit to the country. So what we can do better, I think more of what we're witnessing right now. We're witnessing a bipartisan effort to focus on things that move beyond politics and find a way to at least tackle what we agree on. And I think that through that process should build chemistry and camaraderie. And when we look at what works, we cannot lose focus, treatment, and access to prevention programs and access to life-saving opioid antagonists like Narcan and Cloxato and generic versions. All of those things are incredibly important, but the bad guys have to go to jail. The cartels are a big part of this. They are a threat to this country, particularly the Sinaloa and the Jalisco New Generation cartel, and we have to be incredibly aggressive about that. And unfortunately, many overdoses or poisonings across the country are still being treated as accidental, tragic events. Every person who's dealt from those dealers is likely to experience similar fate. So I've recently had some conversations with incoming Attorney General Pam Bondi. Our association, Major County Sheriffs of America, have had the same conversations, and I think that we're going to see a lot of great progress. So good. More of Thank this you. Is good.
Thank you. And Ms. Matera, fellow Pittsburgher, I want to say I think your grandson is extremely blessed to have your support. It must be emotionally taxing and financially challenging, but it sounds like you're making it work. Unfortunately, as Senator Justice was saying, many grandparents, hundreds of thousands of grandparents across our country suffer through. Any advice that you would offer to families going through a similar situation, and particularly grandparents faced with a similar set of challenges?
The best advice I can offer is to join some sort of a peer-to-peer support group. That has been my lifesaver. Because of my advocacy with Grand Voices, I connect with grandparents raising grandchildren across the country, in the tribal nation, and everywhere. And that's where I get my mojo, because we support one another and we understand one another.
Good. Thanks for that mojo. And Sheriff Lemma, back to you. Just one final question. You talked about collaboration and, of course, common data. Referring to your testimony, common data is an important part of a unified effort. Any commentary on the quality of the data and anything in particular Congress can do to ensure common data standards and availability to combat this horrible fentanyl? Yeah,
I think that we have a lot of great things that are going on, and Congress has really been, responsible for those things. The elimination of the X waiver. I really think that really we should take on permanently scheduling xylazine. Many states have already moved down that path. We're seeing the deadly substance xylazine end up in again, mixed in substances and a growing problem across this country, but yet still is not, scheduled at the federal level. What's incredibly frightening about xylazine, it has, it's a animal tranquilizer.
Frank, yeah.
It really eats the skin away and is non-responsive to opioid antagonists. So these success numbers that were presented across the country in various areas would absolutely decline, or the drug dealer would kind of move down the path to move into that business if we don't kind of tighten up on that. But one last thing is kind of looking at that scheduling of that, and then making sure that we have programs that work. Operation Overdrive is a DEA program that has shown great success, great data tracking. Last report, I think it was in 37 cities across the country. Those should spread out not to new cities necessarily, but into the unincorporated counties that those major municipalities are in. I think that data collection, OD Maps, is another great effort to expand research, data collection, and allow us to kind of let science move the path.
Thank you.
Thank you, Senator McCormick. Senator Warren.
Thank you, Mr. Chairman, and thank you and Ranking Member Gillibrand for holding this hearing today. It's a really important topic, and I appreciate the care with which you treat this issue. Since 2017, the opioid epidemic has taken the lives of nearly 500,000 Americans. Their families and so many more people around this country need Congress to come up with some real solutions. For example, I know that Chairman Scott and I agree on the need to close a trade loophole that lets China ship fentanyl precursors into the country uninspected, and it's time to put a stop to that. But as we sit here today, President Trump and congressional Republicans are working hard to advance budget legislation that would make the opioid epidemic worse and not better. They have proposals to cut over $800 billion from Medicaid, which is the largest single payer of substance use disorder services in the entire country. And why? So that they can fund tax cuts for billionaires. Let's be clear about this. Slashing Medicaid funding, either through per capita caps or backdoor cuts like work requirements in an area that already have work requirements, would mean ripping away health care from millions of vulnerable Americans, including about 1 million people right now who are getting treatment for their opioid addiction. So, Dr. Burnett, you've worked on the front lines of the opioid crisis. You have helped countless people overcome addiction. I want to thank you for your work and express my admiration for that. But tell me, in this budget space, what percentage of your patients rely on Medicaid for their treatment?
I would say currently about 80% of our patients rely on Medicaid for treatment. But,
wow.
Yeah.
Yeah. So, in other words, Medicaid, as I understand it, is not just one option for how people get treatment. It is the backbone of the entire system for treating opioid addiction. Is that fair?
That's a fair comment.
All right. And yet, Republicans are talking about gutting that system to the tune of nearly $1 trillion. So I'd like to look at just a little deeper level about what those cuts would actually mean for our country's battle against the opioid crisis. Two of the policies proposed by House Republicans are capping Medicaid payments to states and imposing red tape like additional work requirements. Dr. Burnett, can you just talk for a minute about how those changes would affect access to treatment if they were put into law?
Absolutely. I think, there was a recent Kaiser Family Foundation study that talks about the work requirements issue, and that actually almost 92% of people on Medicaid already are either working or involved in some sort of part-time or full-time work. So the work requirements situation would just really add a lot of administrative burdens, ultimately resulting in people getting kicked off of Medicaid.
So I just want to make sure we say that again.
Yeah.
What proportion of people are now already subject to work requirements?
92%.
92%. All right, so adding more work requirements on top of this has what impact?
It would certainly increase the administrative burdens of keeping people on Medicaid.
That's right. And what's the consequence of increasing those administrative burdens?
They would lose access to their addiction
That's
treatment.
right. So people just can't get the paperwork filled out. More people fall by the wayside. I think that was the Arkansas experiment, as I recall.
That's correct.
Yeah. But there's another part to this as well. What about capping the funding?
Yeah, capping the funding would create two problems. One, it would definitely curtail the amount of choice that patients have relative to the types of addiction treatment that they would have. And then capping the funding would also create a network adequacy problem because more providers would disenroll from accepting patients on Medicaid, so patients would not have the ability to access treatment close to where they live.
Yeah. In fact, we don't have to speculate on what the consequences would be. In states expanding Medicaid, treatment for opioid addiction increased over 4 times faster than in states that refused the expansion. Meanwhile, Republican states that imposed so-called work requirements did not actually increase employment, because that was never the point. Instead, opioid overdoses went up and access to treatment actually went down. So look, there is no denying the critical role that Medicaid plays in fighting the opioid epidemic. Cutting that program is not just cruel, it's totally backwards in what we're trying to accomplish. Might I ask one more question, Mr. Chairman? Thank you. So, Dr. Burnett, I want to ask about something you've done some scholarly work on and you've published. You've written extensively about the positive effects of investing in treatment and how that ultimately lowers costs down the line. So that if you cut the investments for treatment, like cutting Medicaid, the question is that really going to save any money?
No, I think, as I said in my testimony, people who experience treatment are much more faster to return to work, be productive members of society, and ultimately not be a burden on the social safety net. So it would actually be more detrimental to cut Medicaid funding in terms of the amount of expenditure that states and public dollars would be needing to use to be able to.
So this treatment gets people back to work, fewer trips to the emergency room.
Correct.
Long-term cost.
Totally.
Yeah, is that we save money by making these investments. One study found that for every patient treated with medication for opioid addiction, the government saves up to $100,000 over the course of that person's lifetime. Let's be clear. The budget cuts the Republicans are proposing are not about saving money. If Republicans really wanted to save money, they'd be expanding treatment to folks that claim they want to represent here, rather than ripping it away so that we can bankroll tax cuts for billionaires. Families and communities across this country are counting on us to deliver real solutions to the opioid epidemic, not play politics, and I won't stop fighting for that. Thank you very much. Thank you all for being here. Thank you, Mr. Chairman.
Thanks, Senator Warren. Senator Moody.
Thank you, Senator Scott. And I've always been impressed, Senator Scott, and as a former governor as well of the great state of Florida, you have always dug into the details and cared about things that were harming Floridians. And this committee hearing is a perfect example of that. And you saw how it was affecting seniors. And I don't know how that isn't abundantly clear, and I love that you are the one that highlighted this and brought it as the chairman. When we say working and fighting age Americans are dying at a faster rate than anyone else, the largest bulk of the number of people we lose to overdose death, those are often our parents. They are our parents in this country. And I'm so grateful, Ms. Mateer, that you were here and willing to share your story and your experience. I think it certainly informs everyone and raises awareness that those parents, when they fall victim to addiction, and that affects not only the children, but the generation before them. And I really appreciate you being here. So much of what we did in Florida addressed really aiding many levels, and some of that went to helping caregivers and family members of those addicted. I think it is a false narrative and very short-sighted to say that we have to stop incarcerating drug traffickers. In fact, Sheriff Lemma is a leader in our state I've proudly supported him to numerous boards to oversee not only how we are tackling this problem, but how we are expending the resources that our office recovered, going after pharmaceutical companies, distributors, pharmacies for the opioid epidemic itself. He now helps oversees responsible spending. But we broke it down into, number one, you have to put the peddlers of this poison, the traffickers of synthetic opioids like fentanyl, carfentanil, behind bars, because they will do violence to our communities by selling them lethal doses of opioids or synthetic opioids. And to call that nonviolent, I think, is short-sighted. And I think if we do not take them out of the communities, they will continue to create daughter after son, after mother, after father, falling prey to this. And that is step one. And I'm so proud of law enforcement efforts in Florida. We led the nation at one point in fentanyl seizures. We are focused on that. We have dedicated resources to that, funding, pushing into law enforcement, making sure that they were focused on that and had the resources to go after those traffickers. You can say, honestly, we cannot arrest our way out of this crisis. That is true. But we cannot stop going after the people who peddle poison indiscriminately that our children and our mothers and fathers are taking. That has to be our first step. And going after the cartels and everyone that's helping them spread this is number one. After that, we broke it down into how do we, one, make sure that Narcan is available to family members, caregivers, readily available, and we pushed it to our first responders. Because of that, we are leading the national rate and decreasing the number of deaths that we are seeing every year, and I'm so proud of that statistic. We're going to keep doing better. Past that, we want to make sure that people can receive treatment, good treatment, treatment that's proven successful with few rebounds, and that's done so with science-based methods. I agree that is the case. The problem is, I think a lot of money is getting shoved because this is such a problem and we're trying to fix it, and tragically, we often try to fix things by just shoving money at the problem and not doing a very efficient and intelligent way of distributing that or accounting for that. What would you say, Sheriff Lemma, is the independent body that rates these substance abuse providers?
Well, first, Senator, I want to thank you for your leadership. It was your work that inspired many of us to go down the path in the first place, and I think it's so incredibly important. I also think that for the first time in recent history, the stars have aligned and funds have been made available because of work of attorney generals in various states and big pharma settlement money. And federally, candidly, I think that if you cannot explain what you did last week, you probably don't have that important of a job. And I think when we talk about healthcare is incredibly important and these programs are incredibly important, we said medical-based treatment therapy is the gold standard for treatment, greater access to naloxone. But when it comes to the drug enforcement, connecting the dots, making all of these things work together, I think that there has to be a sensible strategy because many of the cartel members that are in here, they're selling drugs. Some of them are not even legal citizens anyway. It creates an incredibly challenging dilemma. We have boards, we have committees in the state of Florida. We have an opioid abatement settlement team that you led when you were Attorney General, and it has these checks and balances for 20 qualified counties out of the 67 in the state of Florida that have populations of over 300,000 people and a comprehensive strategy to make sure that all of the checks and balances are in place, followed by organizations like the Department of Children and Family in the various states that work through the managing entities that are, again, adhering to the gold standard to making sure that there's checks and balances and people who are responsible for the money at a local level are held accountable to make sure that they're doing the right thing. We don't want patrol cars and fire trucks and water treatment plants because as Big Pharma, who created this by saying proper use of OxyContin, the patient was less than 1% likely to become addicted, and the world said, no, 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 that's simply not true. Well, the money should go to enrich programs that help those individuals and those families.
And thank you, Chairman Scott. I appreciate it. And Dr. Stein, I'll direct my attention to you. One of the things as Attorney General, and I dug into this, was it was heartbreaking to see so many people in Florida and across our nation dying. So I was very hands-in this, and I was shocked to know that there wasn't a directory of sorts that people could go to in the moment when they were ready to get help that had reputable, proven, quality assured treatment with beds available right then. I ultimately ended up speaking with, and thankfully Florida was supportive, and we contracted with a group called shatterproofTreatmentAtlas.org. I think I was one of the first states, certainly Republican states, that was pushing something like treatmentatlas.org, because as you know, as a mother, as a parent, a family member, when somebody's ready for treatment, you want it then, right now, when the bed's available, but you don't want to put it somewhere where they're just going to take your money and churn them out. And so this is what I want to get to. Is there an independent body that is ranking the success of these treatment services that are grasping all the grants and the funding from federal or state government or even recovery settlements?
Senator, thank you for the question. I think it's an incredibly important issue. This is a topic that has come up over a long period of time in terms of helping people find the places that can offer them the best treatment, right? Because as you point out, when someone needs treatment, you need to connect them now. You have a window of opportunity. Unfortunately, I am not aware of any organization that does this routinely and standardly in the type of way that I think many families look for. I think your support of Shatterproof in naming them, they're certainly an organization that has done tremendous work in this area, and I think has been a leader, and many people look to and support the work they've done, and that certainly is helpful. I want to pick up on your comment and sort of point out two things, though. I think one is sort of identifying places that are providing good evidence-based care, medication treatment for opioid use disorder, cognitive behavioral treatment.
But I don't want you to get off track.
Yes.
To your knowledge, is there an independent organization that rates the quality of these drug treatment facilities?
To my knowledge, the organization that comes closest right now is Shatterproof. But I am not aware of anything beyond that.
There's probably very limited attention or resources being given to something like that before we're handing out billions and billions and billions of dollars.
I certainly think that that is one area that absolutely does need attention, yes.
And would necessarily be a helpful filter. Thank you. Thank you, Chairman Scott.
Thank you. Thank you, Senator Moody. Thank you. That's what you did as Attorney General. Senator Kelly.
Thank you, Mr. Chairman. Dr. Stein, and everyone who is appearing here today, thank you. Thank you for being here. It's a very important topic. Dr. Stein, we know, well, based on the conversation with Senator Moody, seniors are rather vulnerable, a vulnerable population when it comes to opioid use disorder. The number of adults who need treatment for this have tripled between 2000 and 2020, I think is what the statistics on this say. And a study from the Moran Company recently found that opioid use disorder costs $4.3 billion each year for newly diagnosed Medicare beneficiaries. If you think about not just newly diagnosed beneficiaries, but if you think about all Medicare beneficiaries and you extrapolate that $4.3 billion each year to the size of the Medicare population, it looks like the treatment for this could be in the tens of billions of dollars.
It's going to make you fall asleep.
So Dr. Stein, I believe, I think we can stop addiction before it starts for many of these individuals that wind up in treatment. And I have a bill that would improve access to non-opioid pain medication for seniors who are on Medicare. Now, my bill would make sure that seniors aren't paying more for a non-opioid pain reliever than they would pay for an opioid. So, Dr. Stein, do you think addressing that financial barrier is important to ensuring folks have alternatives and aren't put on the pathway to addiction?
Senator, thank you very much for the question. I think multiple steps, such as making sure that there are not financial barriers to allow adults who could benefit from non-opioid management of their pain and decreased use of opioids would help to decrease the risk for opioid use disorder in that population. So I absolutely believe the financial benefits is one barrier that's important to address. I also believe that we need to have a sufficient workforce providing these treatments that are available. We need to make sure that
What would that workforce look like? Because isn't it just a decision for a doctor to say, hey, I've got these two options. I've got this non-opioid pain reliever. It costs X out of your pocket. I got the opioid. I'd prefer you take the non-opioid. I understand you got financial issues. You might be on a fixed income as a senior. This is a choice we're going to have to make here. But what is the workforce beyond that?
So absolutely. I think non-opioid medications is one option. But there are also non-medication options that can very much help people. Therapeutic massage, acupuncture. Does it work for everyone? No, but it certainly works for a lot of people and has been shown to reduce the amount of opioids they need. We need to make sure that we have sufficient individuals, so that's an option for the doctor you're talking about, that it's not just opioid or not opioid, but I've got three options. What works best for you and your family? Making sure that Medicare reimburses those services. For example, right now, non-pain management for chiropractors is limited to back pain, but there are other things within their scope of practice that might be useful. Acupuncturists. So I think the financial barrier is one, it's critically important, but there are others to make sure that our older adults get the care they need for the pain to reduce the risk of opioid use.
So the financial barrier extends beyond just the cost of the medication, I think is, one of what you're referring to. Do you have a sense for how many folks wind up on opioids because they can't afford a non-opioid pain medication?
I do not.
Does anybody know of any studies that's been done? Trying to get this sense for my legislation, and if we were to implement this, how big of an impact it would have. Do you think reducing the price of the non-opioid pain reliever would result in less people addicted to opioids?
I think options that allow elderly, like non-opioid medication treatment, to better control their pain are all things. The less elderly exposed to opioids and potentially more opiates than they need, the more likely we're going to be reducing opioids.
And Dr. Burnett, you think that it seemed like you wanted to comment?
Yeah, I would just say that, when we're talking about chronic pain management, a multimodal approach that Dr. Stein is talking about is critical. And this is something that I see regularly in my clinic. And Dr. Stein highlights this point in that you're actually only limited to pharmaceutical options a lot of the time relative to your pain management. And so coverage for the physical and occupational therapy, being able to get into people's homes to be able to improve their living environments and having people go in and make those evaluations and those changes, in addition to aquatherapy, acupuncture, all these alternative and complementary strategies would be instrumental to improving the overall quality of life for people with pain and making their pain much more manageable so that we don't have to turn to the pharmaceutical options and avoid people getting addicted.
Right. Thank you. Thank you, Mr. Chairman.
Thank you, Senator Kelly. So, I ran a large hospital company for a long time, and then I was governor of Florida. And then one of the frustrating things about any issue, this is an example, but I think all of us, have stories that we believe that some sort of treatment, some sort of something is going to save money down the road. And if you believe that, man, you jump at it, right? Nobody comes with an analysis, and nobody ever wants to take the risk. When I was, at times I had hundreds of thousands of employees in some of my companies, and people come and say, "Oh, if you'll do this test, it'll cost you X dollars, you'll save multiples of that in healthcare." I mean, who wouldn't do that? And so I said, I'll tell you what, I'll do it. I'm going to double what I'll pay you, but you take the risk that I'm going to save the money. No, wait a minute. We're not in that business. We're not going to take the risk. And that's the issue you have on all these programs. Nobody wants to go through what Ms. Mateer's going through. Everybody wants to do what all of you have talked, almost everybody's talked about is some program. Nobody comes with data. Nobody comes with data, and nobody's willing to take the risk. I mean, on any program, whether it's a Medicare program, Medicaid program, and so it makes it so difficult to say, oh man, I am all in for doing that because there's no data, there's nothing, and nobody was willing to take the financial risk. Like, I've never been in the insurance business, but you would think, right? If you're in the insurance business and somebody came to you and you could really prove that they could save money by providing this service or this drug or this blah, blah, whatever it is, they would jump at it. But they, for whatever reason, it doesn't happen. So I always ask, the biggest thing I always ask everybody is, are you willing to take the risk? I mean, it's a great story. Are you willing to take the risk that it's going to save money? And if you are, then man, people should jump at that, but nobody does. Sheriff Lemma, can you just talk about your community for a second? And so you're not in a big downtown area. You're more of a suburban and a little bit rural area. How is an area like that most people think of this country? Oh, you don't have drugs in that area. I mean, this is sort of the heartland of America, and it never happened. So how does it happen in an area like yours?
Yeah, thank you so much, Chairman. Seminole County is again the fourth most densely populated per square mile, but we're a small county. We have a population of about 500,000 people and a little more than 300 square miles. Very affluent county, has the highest level of education per capita that does not host home to a major university, and great quality of life, one of the top school systems in the entire state. And when we look at the significance of the reduction, we're proud about that. I talked about a 29% reduction in overdoses or poisonings and a 42% reduction in fatalities. But when you look at the volume of numbers, even of a community like that, the overdoses last year, representing the 29% decrease, is 427, and the fatalities are 66. So if we had a community meeting just there in Seminole County and laid 66 body bags and the tragic effects that they have on the entire family, it would be devastating, and it would be a topic of conversation that everybody would lean in and talk about tremendously. And again, this is one of the most successful counties in the state of Florida based on recent data. Palm Beach County is another county that had a remarkable reduction, 40% more or more reduction in fatalities. I think this is a testament to the strategy that absolutely works. And in addition to that, and I hadn't mentioned it yet, but in Seminole County alone, we've charged 39 drug dealers with first-degree murder for dealing deadly doses of narcotics. And at the same time, we worked with the Florida legislature to change the burden of proximate cause of death to substantial factor. And another key success point there is in areas across the country, the most important thing is to protect and preserve human life, so greater access to opioid antagonists and reversing the effects of the overdose, or bringing people back to life, literally with medicine on gun belts and in back of patrol cars and in private citizens' pockets. But we created a new law in the state of Florida that allows us to charge every drug dealer with second-degree felony culpable negligence if we can prove that they dealt a deadly dose of drugs and we revived them with the use of naloxone. So this is creating momentum. It's something that people are talking about not only in the state of Florida and in our community, but across the country. And we would be happy to share it. And I think that it really, really saves lives.
Thanks. Ranking Member Gillibrand.
Thank you, Mr. Chairman. Thank you to each of you for your testimony. I was very moved by everyone's perspective and the work that you're doing on the ground every day to save lives, and what's happened to your practice and what's happened to your community. It really does matter. Ms. Mateer, thank you so much for sharing your story about your grandson. He sounds like he's a wonderful boy. And you gave some very persuasive recommendations at the end of your testimony. I thought they were excellent. Can you give us a little more guidance on what types of services or supports would make a difference? I have a piece of legislation called Supporting Families Through Addiction Act, which would provide $25 million to community programs so they can provide families with the resources they need to support loved ones battling addiction. So that grant money is pretty flexible, but I'd love to hear directly from you at different stages in your life raising your grandson, what types of supports could have made a difference for you and your family?
Thank you for the opportunity to speak and for your reinforcement. It means so much. I think from my standpoint, when I first was showing up at the pediatrician's office with an infant child, and I wasn't the parent, right then and there, it would have been so helpful for that community to provide me with at least some basic information, where to go for things, what to do, a pamphlet on, what kind of crib to buy, what kind of car seat to buy. Because a generation later, all of these things change. How to feed a baby, everything's different. So I think wherever we touch, it would be good to have some sort of supportive measure in place that at least would provide information. And maybe a list of where to go for resources. What community groups are there where you may get baby clothing, things like that. So I think those things would really be helpful.
So maybe services through pediatricians' offices at a minimum.
Yes, it just seems to me that they don't see the issue. They don't recognize it. Or I know there are so many of us out there, but it's just not above the radar. Mm-hmm. It's just quiet.
Very helpful. Thank you.
Thank you.
Dr. Burnett, thank you for testifying about what you're doing to help older adults access these critical addiction services in your community. In your testimony, you discuss the challenge of accessing evidence-based addiction treatments for those who need it. You also discuss the impact on older adults who are struggling with their addiction. Can you expand on some of the challenges that older adults face with regard to substance use disorder treatment? And are there policy changes that you would recommend that could address some of those barriers?
Yeah, sure. I think Dr. Stein also highlighted this very eloquently insofar as, older adults have a multitude of chronic disease issues that you have to manage in addition to their substance use disorder care. They've got issues related to transportation, polypharmacy, being able to connect your substance use disorder care to their general medical care in and of itself is a challenge. And so, it requires a team-based effort between the nurses on the team, the peers on the team, and collaboration with other physicians that might be taking care of this patient population. So, there's definitely lots of different strategies and policy solutions that we can come up with, largely focusing on Medicare. So, we could certainly expand the Health Parity and Addiction Equity Act to Medicare so that reimbursement for these services could be paid at an equal rate within the Medicare population, because currently that's excluded. We could authorize Medicare coverage of non-hospital-based residential treatment. So currently it is difficult for individuals to be able to participate in community-based IOP and PHP programs because they don't have Medicare doesn't cover that. The Medicare's SUD bundled payments provisions could be increased, and so there's lots of different ways that we could ensure that more providers are be able to take Medicare and take care of those patients with substance use disorder.
Thank you. Dr. Stein, you also discussed some of the challenges with treating an older population with substance use disorder. And you mentioned one of the challenges as being the acute shortage of the workforce and a lack of preparedness among the workforce to treat older adults with co-occurring substance use disorder and dementia. Can you elaborate on this issue and what we can do to help?
Sure, Senator, thank you very much for the question. It's a challenge, right? Because as we've heard, many of the individuals providing treatment are the addiction specialists, and they don't necessarily have this expertise. I think one solution that has come up as I've talked to colleagues is either to enhance training in geriatrics for those individuals or find ways to support those systems in bringing in physician's assistants or people who may have more basic medical training in geriatrics to partner within the care system so they don't have to move back and forth. I think the other one that we really need to focus on, though, is primary care, because that honestly is where the majority of elderly are going to continue to get care. And despite so many of our efforts Many of them still don't provide medication treatment for opioid use disorder with buprenorphine that we know to be effective. And one of our recent studies actually showed that there are probably only about 1,200 clinicians in the country that treat over a third of the older adults receiving buprenorphine. It's highly concentrated. And so I think one of the things we really need to think about is in that group of primary care clinicians treating the elderly. So much of our focus has been trying to get a new clinician to prescribe buprenorphine, but maybe we need to start focusing on the types of supports, whether it be additional supports within the office, better connections with non-physician substance abuse treatment services, to make those clinicians more likely not to just prescribe one buprenorphine, but one elderly patient with buprenorphine, but more of those physicians and physicians' assistants, nurse practitioners, to treat more elderly with buprenorphine. Let's try to build a greater workforce of somewhat higher volume prescribers for the elderly that can merge this expertise.
Got it. Thank you so much. Thank you, Mr. Chairman.
Thank you, Commissioner Duckworth. What's some examples of success that you think we ought to try to do at the federal level?
Thank you very much for the question. Some of the issues in West Virginia, and to the sheriff's point, his county of 500,000 would represent about 1/3 of our whole state. So we're very rural and very family oriented. So going back to the seniors, and what I came prepared with today was the grandparents raising their grandchildren. So helping those folks and getting programs in place that helps the seniors. That's I think it's key. I think we're missing a whole generation of people. We're missing workforce. We're missing, like I said earlier, the whole generation of the family tree is missing. To Senator's point of non-opioid medications, like 50 in every 1,000 of the babies born in West Virginia are addicted to Suboxone. Curbing those things, getting into some of the non-opioid treatments, I think would be a huge success for what West Virginia needs anyway, and where my space is.
Yeah. I think we have over 50 million Americans working age. I think like 16 or 15, something like that, to 64 that don't have a job. That didn't help. So incredible. Dr. Stein, your research at RAND has highlighted unintended consequences of past opioid policies. We know that increased access to naloxone, for example, works. What are some of the lessons learned from past missteps that we should keep in mind in designing future policy?
So I think the awareness that there are sometimes unintended consequences for well-meaning policies is critically important. And so one area that we've certainly seen this and learned about it goes back to actually 2010 and the reformulation of OxyContin, which was approved by the FDA and was well-intended. It took OxyContin at that point was subject to being abused and misused and reformulated it to make that much more difficult. And about 3 years later, that old formulation was taken off. What we've learned in terms of unintended consequences there, though, is subsequently that reformulation led to higher rates of heroin use, higher rates of overdoses from opioids, and the consequences still stay with us. The communities that were more subject to the effects of that reformulation continue to have higher rates of fentanyl overdoses, cocaine problems, and recent research from a colleague actually shows higher rates of child suicide. So I think as we're putting in place these policies, one of the things that becomes critical that we've learned from that is continue to monitor and evaluate. It's not one and done. We can't do these things and turn away. We have to continue to learn because the crisis is going to continue to evolve. And our ability to understand how to respond to the changing landscape requires us to continue to pay attention.
Sheriff, are there any different law enforcement issues dealing with seniors? Is there anything more challenging?
Yes, Chairman. I think when we look at the baby boomers, particularly, they're named baby boomers for a reason, and we saw significant population growth in that time, and we find many of that generation are evolving into really some dependency. And what I think the unintended consequences of COVID was a senior population was thrusted into having a greater online presence that they weren't necessarily prepared for. A clue is if you're still paying $25 for an AOL account, you're probably victim, a prime target for a victim of some online scamming. So we're seeing increase in white-collar crimes and victimization of seniors. When it comes to substance use and all of that, I think that we've always tried to balance the need for really reliable services, and opioids have its place in certain environments, and making sure that people who need the medicine are not getting it, not living in pain as a result of it. And I think that back when you were governor, we saw that occur in the state of Florida with prescribing 3 and 7 days and for acute pain, and then so prolonged issues, whether it's cancer or other type of items. Seniors are able to get access to that. But again, the greatest increase that we're seeing is victimization, because many of our senior population were thrusted into this online presence, and because of that, they become more vulnerable.
Yeah. Well, I just want to thank each of you for being here. Thank you for caring so much about this issue. It's impacted. I don't know actually of a family that's not been impacted either by alcohol abuse or drug abuse. I mean, everybody has. I lost my brother last spring, and he started out using marijuana, eventually used all the drugs, and he impacted his life, and so it screwed up. And it doesn't just impact him; it impacts my whole family. So just you feel sorry for everybody that goes through this. So thank each of you for being here, and I want to thank the ranking member for her hard work. Thanks.
Thank you.